Hello, everyone. My name is Thuan and I'm a faculty in pediatric dentistry at the University of California, San Francisco. Today, I will present to you a lecture, and the title is Infant Oral Health Care, Dental Home, and Referral. It is very important to establish an early infant oral health care program for children. And also the concept of dental home, basically a dental office where if you identify problems and you can recommend the parents to come seeking for help. And once in a while, you would run into the situation where you see a complex dental problems where you have to refer them to a specialist in pediatric dentistry or general dentist who train to take care of children. In pediatric dentistry, one of the most challenging thing is to get for the infant oral health care program up and running in the dental office is actually to convince your staff, RDA, and dental hygiene that what you're doing is making sense. Because a lot of people would wonder, why in the world would anybody want to see a young child when they have only 2 teeth or 4 teeth, etc., and there's no dental caries. So it's very important that you try to establish so that your team member would agree to it and buy it in. And that takes a lot of education, a lot of training on your team, okay? But the earlier you establish the program, you're going to help children quite a bit, because early oral hygiene programs should be established at home, and it's going to have a very beneficial effect by promote oral health early, and therefore you set a child on a path of great oral hygiene for the rest of his or her life. The objective of today's lecture is to provide the health professional students with the motivational to consider an infant oral health program in his or her practice. This could be pediatrician, nurse practitioner, non-dental professional to participate, and also to provide some ideas as how to make it possibly profitable in life. You have to be able to get the reimbursement for your work in order to maintain the operation and enjoyable doing it, because the experience going to help children greatly and also help the parents as well. Well, the reason why some practitioners do not want to perform the 1-year infant oral health evaluations, I must admit, you treat a young child early on, the kids will cry. And when children cry, it's stressful. So there are a lot of reasons out there why some practitioners do not want to do 1-year infant oral health evaluations. Below are just some of the examples. For example, existing conditions should dictate when a patient is seen, not his age. For example, a lot of parents do not want to bring a child into a dental office until they have teeth, because without teeth, why would I bother to come to see a dentist? But the fact of the matter is, the first visit should be between 0 and 1 year old. Even when the child have no teeth or maybe have 2 teeth, because when you bring the child into a dental office or to a healthcare professional early, most likely the parents and the child will receive very useful information as how to take care of the oral hygiene. Parents often don't see the reason for or the value of infant oral health exam, and again, because they don't see a problem associated with the child's mouth, so they consider there's no issue, so they don't think about coming to see a dentist or a healthcare professional that want to look into the oral cavity. There's very little decay in my community where I practice. A lot of people just assume that because in the affluent community, children don't have dental caries, but who knows? Dental caries can happen to anyone. Okay, parents should decide when and when their child should be seen by a pediatric dentist. A lot of time, parents want the best for their kids, but they don't really know the right information or when to see the child. So it's good to establish a routine that the child should be visited by dentists by the first year of age. Okay, and patients are not covered at that age. it's true. I mean, usually children under 3 years old, they're not yet able to cooperate. They're still in the stage of precooperative stage, not yet able to cooperate. And it's normal for a child to cry at that age. I wouldn't worry about that. It's actually normal when they cry, they open the mouth wide, and therefore it's allow examination. Okay. I'm too busy treating older patients and seeing infants would be disruptive in my office routinely. It's true because when a clinician who tend to treat older patients, and when suddenly the young child comes in an office, he or she may cry. And when they cry, it could be disruptive, it could be stressful for staff or a dentist. But with good, adequate training and good experience, then the clinician could feel comfortable seeing the kids and shouldn't be a problem. It is difficult to get insurance to reimburse for infant oral health exam. It used to be the case, but now it reimburses for children oral health under 3. Okay. Another factor that prevent people from seeing child early is that infant oral health exam tend to frighten the child, and I don't want to create a dental phobic for children. It's not true. I mean, kids just cry because under 3, 1, 2 years old, they have separation anxiety. They like to be with their parents only. They do not like to be with a stranger. So for a child to cry at that age is completely normal. Okay. The reason for embracing the 1-year infant oral health, there are many, many beneficial factors for a provider to see the child early on. Okay, it is very easy to do because he or she is small, it's easy to manage. They only cry, but again, that's really normal. They're going to open wide for you to do a complete thorough exam. And it can be profitable because you do not need to involve a lot of staff in the process. It's quite simple, it's quick, and you can get the reimbursement for the exam. It can be a great practice builder. The reason because this is the opportunity where you provide useful educational information to the parents so the parent can carry it home and apply to their children. Okay, and in the process of doing so, parents tend to perceive it as if you are a very caring provider. So they will stick with you. When the child get comfortable with the dentist or provider, they will stay. They will not go anywhere. And that become a long-term asset to the practice. It is rarely appreciated as educational opportunity by parents when conducting with anticipatory guidance. So while you provide education, anticipatory guidance is a critical component, okay? Meaning that the provider have to ask questions, guide the parents through about dietary counseling, the recommendations, sugar challenging, frequency and durations of carcinogenic food and drinks. Also, teach parents recognize abnormalities, dental caries, staining, eruption sequence of teeth, as well as any potential oral habits such as pacifier, thumb sucking, so that parents can seek out for early interventions and suggestion, recommendation, etc., to prevent the problem become too late. Okay, it also provides an early opportunity to truly prevent dental disease. So now you train the child, the parents, into a preventive mode instead of reactive mode. Preventive mode means prevent the disease, the caries from happening, versus reactive meaning you wait until the problem arises. So being reactive is very difficult to treat versus preventive. A lot of times children under 3, it's difficult. They cry, they're not going to cooperate well. Or conscious sedation may be contraindicated because the airway is too small and narrow and is outright dangerous. The other option left is general anesthesia. It could be costly. There's a risk associated with general anesthesia. So all in all, it's good to be on top of things and practice prevention instead of reaction to the problems. Well, the most compelling reason not to adopt the 1-year oral health exam is this. If we don't do it, somebody else will. And I can assure you this is going to happen. The reason because if you refuse to see a child early, the dentist or provider next door would do that, and therefore you potentially lose a potential customer in the future. So learn it, practice with it, and move forward with it. Okay, Into the Mouth of the Babes. It is a program that was initiated in North Carolina in 1999 and was expanded statewide in 2001. This allowed private practice physicians, MDs, and nurse practitioners to apply fluoride varnish in Medicaid children aged from birth to 3, and they're able to reimburse for the services. So this program allows non-dentist provider, these are primary health care practitioner, to apply fluoride varnish, which is one of the most effective preventive mechanism for prevention of dental caries. The way fluoride works is that it's going to modify the outer surface enamel into a fluoride substituted carbonate hydroxyapatite, and the layers seem to be harder than the original substance of the enamel, and therefore it resists the rate of acid demineralization. That is the primary mechanism to prevent decay from happening when you apply fluoride varnish. Now, California reimburses physicians for applying fluoride varnish as a means to prevent early childhood caries. And 7 states now also permit the unsupervised practice of dental hygienists. So there are more and more states now allow dental hygienists, whether with the general supervision or unsupervised dental hygienists, to apply fluoride varnish, because the program of fluoride application is so effective. So we want to expand that network and allow other primary care practitioners to participate. Where to begin? Once the decision is made to incorporate an infant oral health program in your practice, there are primarily 3 areas to which to focus to assure the success. The 3 players are the internal players. These are staff and employees, and of course, patients, families of record. Okay. The next group is the professional, is the dentist, the physician, the nurses, the PA. These are the providers. And finally, the public, because you need to educate the public about the effectiveness of early childhood, infant oral health. Okay. So here you have a group of patient, staff and employee, a dentist, the professional who help to apply the approach. And finally, we need to go out there and convince and show the data, the information that early intervention, infant oral health care is very highly effective. So first and foremost, we need buy-in and total acceptance of the concept from our staff and employees. To get this buy-in, the provider, the dentist, need to be educated, and the person who provides the education, of course, is going to be a dentist. We have to present to our staff and employee from the concept of infectious disease paradigm. It is true that dental caries is an infectious disease. It's caused by bacteria, and this carcinogenic bacteria, namely Strep mutant lactobacilli, they can be transmitted from parents to children as vertical transmission, or horizontal transmission between siblings or at school among children. So the idea is that we try to eliminate or reduce the amount of bacteria in plaque, therefore reduce the frequency and severity of transmission and caries. We have to establish the dental home concept early, because once the parents at home able to recognize anomalies, the child develop infection, parents would know exactly where to go to seek for help. That is the dental office. So the dental home concept is that the child, the parents know where to reach out for help when they needed it. And also, we have to conduct caries risk assessment. The caries risk assessment concept is that the provider, the staff had to ask parents, the child, questions. This comprises of protective factor, okay, as well as risk factor or disease factors. For example, they would ask questions about carcinogenic diets, the duration and frequency of sugar challenge. They would ask about whether the child used fluoridated toothpaste. That's a protective factor. and also in combination with the clinical finding, such as plaque, gingival inflammations or gingivitis, bleeding upon brushing, also the history of the disease of dental caries. When was the last time they have dental caries? Okay, how many months, how many years ago? So together we can assess the risk, whether it's low, high, or moderate, and therefore we recommend the intervention accordingly. They have a worksheet for this, so we have to go through each item and we provide a numerical score, and at the end we total the score together, and then we can decide whether it's the child has low risk, medium risk, or high risk. We also discuss about anticipatory guidance. Anticipatory guidance is a concept that we teach the parents the recommended low carcinogenic at home. For example, acidic environment, sugar, high concentration of sugar, acidic environment would be bad for the teeth, and therefore you have to reduce the frequency as well. The duration of sugar challenge. For example, soda drink would be a negative thing for teeth. Prolonged milk bottle. The child sleep with a bottle at night is a big no-no, because then they're going to cause a lot of caries. The carcinogenic bacteria known to utilize the glucose, okay, and they reproduce, establish thick plaque, and these bacteria will secrete lactic acid. The acids would cause the pH to drop, and therefore demineralization would take place. That's one concept, anticipatory guidance. Other concepts include the use of pacifier. In the first year of life, the child tends to use pacifier to provide peace, etc. There's some controversial benefit about the use of pacifier, just a reduction of otitis media or prevention of sudden death syndrome, but the pacifier use should be weaned no later than by 3. Okay, same as for thumb sucking. It had to be discontinued no later than 3.5. The reason, because if there's prolonged habit, the child will experience permanent skeletal damage, and therefore it would be very costly for orthodontic intervention. Now, the next item we would train our staff to do is motivational interviewing. These are, we ask questions, listen to the parents about respond, capture what motivated them, okay, and build on that rapport. For example, if the child had heavy plaque, gingival bleeding upon brushing, then you ask about frequency, the oral hygiene habit at home, and parents may respond, oh, my child loves to brush their his or her teeth. I say, that's good, okay? And we would recommend that the child continue to brush, even though he or she may not develop proper manual dexterity for brushing at this time, because children under 5-6 years old do not have proper manual dexterity to brush teeth yet, but we still have to provide them with a toothbrush, allow them to develop manual skill, and the parents have to jump back in and rebrush everything. So you capture what they tell you, what the child like to do, what the parents like to do, and try to modify to improve the process, okay? Now, with receptionists and front desk staff, we have to present in-service PowerPoint presentation to cover the rationale of oral health exam, okay? How to answer those frequent asked questions from the parents. The introduction of caries risk assessment, again, I'll briefly mention about that. We have a list of questionnaire items that we have to go through and ask the parents yes or no, and then we mark it so that later we can score them to assess risk. And caries risk assessment itself is an entire different lecture. And again, we talk about motivational interview. We need to train our staff, the front desk staff, to do the right thing, to answer appropriately to the parents. Okay, I will give some of the example of the frequent asked question. For example, parents must say, well, my pediatrician suggests that I make a dental appointment for my 11-month-old daughter. She has only 8 teeth. Why on earth she needs to see a dentist, right? Well, 11-month-old is near 1 year old. It's almost like the recommendation for APD is that the child first dental visit should be during the first year of age, because by 1 year old, the child have several teeth. At least you get 4 upper anterior, 4 lower anterior, and the posterior first primary molars. So that's a lot of teeth. And it's important that we can teach the parents or provide the information how to care for those teeth, mainly brushing in the morning, brushing at night, and making sure flossing between the heavy contact area, just to completely remove the bacteria, the biofilm that stick on the teeth. So it's quite important, because many children may come in too late. By 1, they have a full mouth decay. For example, the baby can suck on the bottles, walking around the house all day long and at night as well. And by the time the child reach 1 year old, they have severe early childhood caries. Almost every single tooth have decalcifications, active decays, and it's really hard to treat. Then we have to put the child under general anesthesia, which is very costly in order to get it done. So yes, it's important to come to see a dentist before the age of 1. All right, my pediatrician told me to take my son to a dentist when his front tooth come in. But my dentist say he does not want to see him until he's 3 or 4. What should I do? Well, in that scenario, you come to a pediatric dentist or a dentist who are willing to see a child, even one tooth, one single tooth. And it's really poured down to the background training. Some dentists, they don't have a lot of exposure to children and feel uncomfortable to see a child because the child may cry. And this is very disruptive, it's stressful. But with good training and experience, it shouldn't be a problem. Actually, it's fun. So I would recommend to seek out for a dentist who will see a child early on, even one tooth, because during that session, the parent would receive very useful information about how to care for teeth, how to establish good oral hygiene, what to anticipate when baby teeth come in, when baby teeth exfoliate and adult teeth come in, how to care for them, and also prevent future oral habit, such as thumb sucking, prolonged pacifier use, tongue thrust, digit sucking, etc. Okay, and perhaps you may even recognize some anomalies early on so that the child receive proper intervention. My 18-month-old baby does not like stranger. Of course, the child will not, because they're in the precooperative stage of development. The child not able to cooperate. So he or she may cry, and that completely normal responses, okay, from a child. They don't want this separation anxiety. They just recognize the parents, but not strangers. So that's normal for 2 years old. I know she will cry if I bring her in for an appointment. What will you be doing on the first visit? Now, a provider have to assure the parents and have to demonstrate the level of understanding about child development and quality development of a young child. You have to assure the parents that crying is a normal response, and then there shouldn't be anything to worry about to the parents ahead of time. Then you explain that you're going to conduct a lap-to-lap exam. The child may not be able to stay in the dental chair by him or herself, so we'll conduct a lap-to-lap exam. A lap-to-lap exam is when you sit the child face toward the parents with the leg strata against the waist of the parents, okay, face toward the mom or dad. And when the dentist is ready, the child will lie in the supine position. The parents will touch the knees of the dentist. And we just ask the mom or the dad to secure the wrist. Let the dentist take care of the head area. And I usually go in with a toothbrush, just try to gently brushing the teeth and massage. The child may cry or may not cry that way. And just after brushing, you can assess several things. You can evaluate whether the gum is inflamed, because inflamed gum would bleed while you brush. A healthy gum would not. Okay, and if the child cry, he or she tend to open wide and allow you good visual inspection of the oral cavity. So you would explain to the parents that during the first visit, you conduct a thorough oral exam, okay, making sure the gum health is great, making sure the child have no cavities, and provide all the useful information and have the chance to respond to questions the parents may have. Okay. initial contact is a good time to introduce the concept of caries risk assessment. The concept of caries risk assessment is really important in our specialty. I mean, we have to treat dental caries as infectious disease. And from the infectious disease standpoint, it's important to assess risk, because once the risk is established for a child, whether it's low, moderate, or high risk for dental caries development, then the provider can specifically provide specific recommendations for each of the child. And it may be different from one child to the next. For example, if a child is low risk, then you may not even worry about taking x-ray so frequently. If a child is high risk, then you should take it more frequently. Recommendation, the use of fluoridated toothpaste. I know that a lot of parents tend to be concerned about fluoride in the toothpaste. But the fact of the matter is, if all toothpaste, the concentration of fluoride are very similar across the board, whether adult toothpaste or children toothpaste, there's no difference. The only difference between adult toothpaste or children toothpaste primarily is the color and the taste, because if it's for a child, they tend to put a little bit of a sparkling, make it fun, as well as bland. It's not too minty and spicy. The child may cry if that's the case. But if you look at the fluoride concentration, whether it is a 0.24% sodium fluoride or 0.45% stannous fluoride, if you convert that fluoride into part per million, they probably fall into 1,100 part per million. They're identical. Okay, there's not a whole lot of difference. The idea is this is the part of anticipatory guidance here. You tell the parent to use a pea-sized amount of fluoridated toothpaste, okay, not the whole blob of it, because the child may swallow, and chronic swallowing of excessive amount of fluoridated toothpaste can result in fluorosis. So it's just a pea size, a smear layer on the tip of the toothbrush. That's plenty. And if the child were to swallow that amount, it wouldn't cause any harmful effect. So control the amount of lye for the toothbrush, okay? Because fluoride is really important for caries prevention. So I highly recommend that, okay? We have to teach our team members to be familiar with all the tools. It could be a worksheet for caries assessment, the specific kind of question we will ask the parents on that worksheet to identify protective factors, identify risk factor, and also disease factors, okay? And how is it to administer this question and record the result, okay? And how it used to identify infants who have increasing risk for development early childhood caries by summarize the finding on the worksheet of caries risk assessment. Now we have to train our staff on this issue. Okay. Risk group. Children, the high risk group that tend to have poor oral hygiene and develop dental caries, these are children with special needs. If you have a child come in with autistic or Down syndrome or any other craniosynostosis or cardiac conditions, or immunocompromised, these are very high risk group, meaning that they lack ability to take care of their dentitions for whatever reason. So as a result, they tend to develop very severe and generalized pattern of decay in the mouth. Children of mothers with high caries rate. Now we know that dental caries is an infectious disease, would mean that it's caused by bacteria. It can be transmitted from mother to the child. So it makes sense that if the parents or primary care provider at home have active caries, this is strep mutans, lactobacilli, these bugs can be transmitted down to the child by sharing the same utensil, spoon, food, etc., saliva, okay? Children that demonstrate significant amount of plaque, staining, demyelinization, or caries, and that makes a lot of sense too, because plaque means you have potentially high bacterial counts that known to produce lactic acid and create a drop in pH and lower pH, primarily lower than 5.5. Then the enamel will demineralize, and that is the initial lesion on incipient caries at first, and if it's happened over a long period of time, the decay will become more severe, and frank caries will develop. Children who sleep with bottle or breastfeeding throughout the night. Now the key is throughout the night, okay? I mean, some kids have to depend on nutrients from the milk, and so be it. But once the parent decide to give a bottle with milk to a child, it have to be at the frequency and duration. If you give the bottle of the milk so many times throughout the day and over extended hours, over a long period of time, that's detrimental. You rather give to a cup, let the child finish it, and after that you brush your teeth before they go to sleep. Do not ever give a whole bottle to your child, sucking, walking throughout the days, throughout the night, because then the teeth would constantly being challenged by sugar in the milk, okay? And this sugar will be utilized by bacteria, and bacteria will proliferate, and they produce a lot of lactic acid. So early childhood caries, or severe early childhood caries, is very prevalent, and it's occur children with this age group, and it's difficult to treat because then we have to provide general anesthesia to treat this child, or sedations may be possible in some kids, and a lot of times children at this age, they small, obstruct airways, etc. So it's maybe a contraindicated for all kinds of sedation. So what's left is, if parents decide not to go to general anesthesia, sedation is out of question, we potentially can use either varnish or SDF, which is silver diamine fluoride, to apply on all these caries teeth just for the purpose of rest dental caries, but not the fetal treatment. Okay, so stop using the bottle asleep or breastfeeding throughout the night. That's the key. Children from families of low socioeconomic status is also belong to this high risk group. The reason because low dental IQ, and perhaps parents are extremely busy working, try to meet and meet for the child, for the family, so they don't have time to think about the oral hygiene, the brushing of those teeth for the children. And there's a lot of studies to support there's a strong caries prevalence correlated with low socioeconomic status among this family and their children. Scheduling, okay? The office have to help establish a policy for scheduling preferences, because initial oral hygiene or infant oral hygiene exam can be integrated into a regular office schedule. I would recommend that either block out an hour at 11 or 12 p.m., 11 to 12 p.m., the last hour of the morning session or the last hour of the evening session for infant oral health exam. This is the downtime of the office. You do not need to involve a lot of staff for this procedure. It's really about a toothbrushing, fluoride varnish applications, and spend time to educate the parents with anticipatory guidance. So it's less stressful time. So the office can establish the best time to do this procedure, okay, for infant oral health. Okay, with the clinical staff orientation, you have to train your staff again. You have to present PowerPoint for clinical emphasis and teach the staff ability to do knee-to-knee exam. Okay, knee-to-knee exam. I already briefly described how to do it previously. Also, teach the staff how to set up on the tray, what material you need. On my tray, I would need a mouth prop, which like a tooth pillow. It's helped to maintain the jaw opening. I would need the toothbrush, okay, and I need floss, okay, because with the brushing, I also not only remove a plaque, but I have the ability to check for gingival inflammations, bleeding upon brushing, and then I would floss, because after you brush and floss, you also provide demonstration to the parents, okay, is how to brush the teeth properly and how to floss to prevent interproximal caries. Okay, I would need to have a fluoride varnish package there also, because in a couple of gauze, explorer, and mirror. Okay, so then after the brushing, toothbrushing, and then you can pick up the explorer and the mirror to check for teeth. You have to establish an oral exam pattern. You're looking for soft tissue. Perhaps you start lower left, move to lower right, upper right, upper left, looking for soft tissue in the buccal vestibule. Then you're looking for soft palate, okay, hard palate, looking for any abnormality, aphthous ulcer, craniosaur, fibroma, papilloma, any evidence of petechia in the soft palate, any evidence of viral infection, such as herpes infection or herpagina infection on the soft palate. Then you move down to the dorsal and ventral tongue. After that, that concludes soft tissue exam. And you're looking for hard tissue exam, looking for occlusion. Is this flush terminal plane? Is it measure step, etc.? Because this is great future prediction of the permanent tooth occlusion, class 1, class 2, or class 3. I would look for extra teeth, lack of teeth, any occlusal discrepancy. These are hard tissue anomaly. And the last thing I would do is to look at dental caries, okay, tooth by tooth, okay? So those are the things that you have to teach your staff, the instrument necessary to be on the tray so you don't have to get up and run around and looking for it while the kid's crying. And then perform risk assessment, as I briefly mentioned early on, and anticipatory guidance. This is an opportunity to educate the parents, okay, about how to take good care of the child oral hygiene, how to brush, how to floss, reduce frequency of sugar challenge and durations, the prevention of oral habit, the normal sequence of teeth eruptions, and try to dispel some of the myth about fever that associate with teeth eruption, which is unfounded. It's just coincident. During that time, the child go to school, immunity develop, and they tend to pick up the bugs from their peers, right? And it's also the time when teeth are very busy coming in. So it has nothing to do with fever, okay? And parents would anticipate a lot of saliva flow, okay, drooling, etc. So, and ask parents if you have any questions. So that's a great opportunity to teach education. Okay, while a provider or your staff or dentist conduct need-to-need exam, okay, what you look for? You're looking for plaque, the evidence of plaque. Usually they tend to accumulate along the gum line. If a heavy plaque, it can cover entire tooth or two-thirds of the facial, the tooth surfaces. Any evidence of gingival inflammations. When a gingiva is inflamed, it tends to be red, bulbous, and tend to bleed upon brushing, okay? Any evidence of stains, particular plaque stains. Some children have iron supplement. Those kids tend to have a severe stain even, and this is extrinsic staining that can be removed by prophy cup. However, sometimes you detect the intrinsic staining. This is the kind of stain that actually inside the dentin. And if you see some intrinsic staining, you ought to ask the parents question whether the child have any past events of trauma. He walk, he or she fall, it's knock on those teeth, and teeth can get turned dark or discolor, right? And in that case, you need to take a PA just to make sure the tooth is not necrotic or dead. And again, it's also a part of anticipatory guidance about trauma prevention. Kids begin to learn how to walk about the age of 1, and they tend to fall. Okay, and so we have to watch out, making sure that the child live in a safe, comfortable environment, out of all the object and danger. And it can happen, a child fall, and they're gonna hit the teeth, and teeth get stained. Okay, we're looking for demyelinizations. These are white spot or early incipient caries. And then we can teach the parents how to take care of this area so you can promote remyelinizations with fluoridated toothpaste. Okay, we don't usually prescribe Prevident 5000 for children under 5 years old because that toothpaste has very high concentration of fluoride, and children under 5 they tend to swallow them and result in fluorosis. So we try to hold on the supplementation or prescription of high fluoride toothpaste for kids under 5. And any evidence of frank caries, because with frank caries we can do SDF to arrest them. We can do more frequency of fluoride applications, or for those that are severe, then we can think about definitive restoration. Okay. Okay, the important point to take home is that when establishing an infant oral health program in a community base, it is a collaborative effort. The good interaction between a dentist, could be a pediatric dentist, with other pediatric medical providers, could be the registered nurse or pediatrician in order to achieve the goal of having all the infants to receive oral health risk assessment early and establish of a dental home by the age of 1. Okay, the better we start, the better for the child. Okay, the enhancement of children oral health by educating the medical care provider. Again, we have to emphasize the importance of first-year infant oral health evaluation to pediatricians and other primary care providers in our communities. We have to provide instruction and guidance on, again, caries risk assessment is really important. It is a lecture of itself that I will present later, okay, on how to conduct caries risk assessment. Complete oral health evaluations, okay, looking for normal structure as well as abnormalities, okay. The basic oral health evaluation, which itself another separate lectures, looking for common cause lesion and how to deal with them. Once in a while, or you will anticipate or will experience complex dental problems that beyond the scope of practice, your scope of practice, and therefore it is important, it is appropriate to refer to a specialist, to a dental home, to a dentist, so that the dentist can provide proper care for the child. Then how to apply fluoride varnish, okay, or may apply SDF, right, in the moderate or high-risk infant where they already have dental caries, and refer the patient if that's not possible, okay. So the way to apply fluoride varnish, again, you have to establish a system. I tend to dry the teeth first. I can start for the upper arch. You dry the teeth and then you apply fluoride varnish. The reason you work upper arch is because some kids, when they taste the fluoride varnish, they will cry. They may not like it, okay? So you finish the upper arch and you finish the lower arch because the tongue tends to touch the fluoride varnish more rarely on the lower arch than the upper. So I start out with upper. The teeth need to be dry. The reason because this is resin, fluoride varnish is resin. They would set upon contact with saliva. So when you dry the teeth, you apply fluoride varnish, and after applications, the saliva will contact the material, and the material will set. And when it set, it stick on the teeth. If one apply fluoride varnish when the teeth is moist and wet, it's not as effective. So the teeth need to be dry first. Okay. If you see active dental caries, and for whatever reason the child unable to receive definitive restorations, then SDF, silver diamine fluoride, would contain about 44,800 parts per million of fluoride, with twice as much fluoride that of fluoride varnish. Fluoride varnish has about 22,000 parts per million. SDF is highly effective for arresting caries. It's not definitive treatment, but at least it slows down and arrest the lesion, the decay. However, the only drawback is SDF will stand teeth plaque. All right, so be careful when you apply. Make sure it's not spilling everywhere. Have a good control. Dry the teeth and gently rub the material with the cotton applicator onto the lesion, and then wait for a few seconds, and then blow the air again just to evaporate the content. Highly effective. Use quite a bit of that. Okay. All right, and to enhance the children oral health by educating dentists in our community on how to comply with the guideline from American Academy of Pediatric Dentistry as well as American Dental Associations on the guideline of the establishment of the dental home by the age of 1. So there are 5 million dental children in California alone. And it is quite evident that there are only 600 practicing pediatric dentists throughout the state. So these populations of dentists cannot provide the dental home for all of the at-risk children. So we do need general dentists to adopt the infant oral health as a priority. So there's still a lot of education need to be done even among the dental community and general dentists, so that altogether we provide excellent oral health care early on for infant and put them on a great path to an excellent oral health in the future. Thank you for your attention.